to the endocrine session, or advances in pediatric endocrinology. For this session, we have 3 speakers. One is myself. The other one is Dr. Erica Vandenacker, who's head of pediatric endocrinology in the Netherlands, and also Dr. Theo Suss from the Sophia Children's Hospital. And we, at the moment, I'm going to go first and talk about diagnostic approach to disorders of sex development. And then we need to see, because one of the speakers at the moment has difficulties dialing in, and it might be that Dr. Theo Suss goes second. And what I'm going to do is, I'm a pediatric endocrinologist from Sheffield, and have an interest in inborn errors of steroidogenesis, congenital adrenal hyperplasia, and DSD. And I've been asked to talk about the diagnostic approach to disorders of sex development, or differences in sex development. And rather than going through an algorithm or something, what I thought is I'll give you a few thoughts. First of all, I have nothing to disclose in relation to this presentation. Then, okay, so as a starting point to give it a thought, how do DSDs occur, and what are the origins of it? Usually, it's a problem or a difference happening during embryologic and fetal development, and quite often due to numerical or structural variations in sex chromosomes, or due to variations in genes involved in gonadal and genital development. There's other forms of disorders in gonadal and adrenal steroidogenesis, sometimes maternal factors, which could be endogenous or exogenous. Endocrine disruptors have been implicated, and there is an increasing body of work suggesting that epigenetic changes disrupting gene expression during the fetal period might be an underlying cause of it. So it's a huge variety of underlying causes why you might have a DSD. Well, the key bit here is, diagnostic bit is, and let me start off with the idea, what questions do we try to answer, and why do we try to answer those questions diagnostically? First of all, we want to have some information about gender development and also sex assignment, assessment of adrenal and gonadal function, potentially gonadal cancer risk later on in life, and other cancers in associated syndromes. Then other associated morbidity, and I can't go into detail here because there's so many different problems that might occur. And we want to give patients and families also, and parents, an idea about long-term outcomes, risk of reoccurrence, and also to provide a good basis to counsel families. So the question is really what tests to use to answer these questions. And I have to disappoint you here at the second slide that I might not give you 100% conclusive answer, and can't give you a cooking recipe how you need to do it, but I'll give you a few ideas. So let's go a step back. So with disorders, or with DSDs, you will be aware that since 2006, there's a more systematic nomenclature with 46X, OI, 46XX, and other forms of DSD that made it a bit more systematic in terms of clinical. You will be aware that there are discussions about the terms of disorders of sex development or differences of sex development, but the classification for a diagnostic workup works quite well, and is by far more conclusive than previous terms used. The main bits, and that's also, or main different categories, and we can discuss that for hours if Klinefelters or Turners are DSDs or not, which in my opinion, I have to say they're probably not, but they fit nicely into this medical classification. Then forms of mixed gonadal dysgenesis or other forms of chimerism. Another group are 46XY DSDs, so people with 46XY chromosomes, and then with larger categories of disorders of gonadal or testicular development, androgen synthesis and action, and other, because there are quite a few different reasons, and 46XX with androgen excess, and the majority of those are 21 hydroxylase deficiency, some 11 hydroxylase deficient, and then many other rarer, way rarer causes. So let's start off with an example of a patient to exemplify a few things. So that's a newborn. So this baby was born with a bifid scrotum, ovate palpable structure in the labia or labia-like structures, and these are usually not ovaries, because ovaries don't drop out of the tummy, or only very rarely. So this is a hint that this might be something tested or tested-like structures with a very small phallus. And so this is just something in medicine we always, I believe we're not very good in having objective criteria, because I have no idea what a lentil or a pea or whatever is. So I'm going to come to this in a second. That might be useful to have some quantifications, and then normal birth parameters, a cleft palate and low birth or low blood sugar reported. So what do we want to know when we take the history in terms of the diagnostic process? So one bit here is asking those parents about prenatal exposure to androgens such as progesterone and other stuff, or potential endocrine disruptors. And there's only a few examples here in terms of drugs. What I would do is ask for maternal virilization, that because there are rare forms of oxidoreductase deficiency, placental aromatase deficiency, luteum, and a few other even rarer causes. And then the family history, ask for other people in the family who have been childless or amenorrhea. Could it be androgen insensitivities or other forms in the family, unexplained infant deaths, hinting towards adrenal insufficiency. And then consanguinity, or a more homogeneous population, because there are obviously areas with increased consanguinity, etc., where you have a chance for one or the other condition being more likely than the other. So going back to this chap, and what we do is also in terms of quantification is using an external masculinization score, and this has been published quite a few years ago and developed by Faisal Ahmed. It's been published here in the UK guidance document towards for the diagnosis of a child with DSD. You can classify things according to scrotal fusion, micropenis, urethra meatus, the location of the gonad. And this chap here has a very low EMS, certainly further warranting further investigations. There are newer scores now which have been developed, but that's fairly comprehensive. If we look at, on the other hand, 46XX DSD, then you might be aware of Prada stages, which go with the appearance of the external genitalia and different bits of the internal genitalia with the urogenital sinus from Prada stage 3. The bit is you can't really use a Prada stage, and in 46XX and in 46XY individuals, this is reserved for 46XX, whereas the EMS is better used for 46XY. And then just to give you a quick example is, it would be good to have standardized data collection. And this is just an example from the IDSD registry, and this is how we collect the data, looking at, have we got labial scrotal fusion, where's the gonad, and all the other stuff, rather than having this lentil-sized appearance. And there are good centites for penile length, for clitoral length, and other things to quantify things in the clinical scenario, make it a bit more objective. In terms of initial diagnostics, what we need to start with is a karyotype and a FISH analysis to have an idea if it's 46XX or 46XY. Do an ultrasound to have a look at Mullerian or Wolffian structures. And then there's quite a few other bloods, and I'm not going to go through this entire table. The only thing I would like to say here is, in the first go, particularly if you don't have if you don't see cases or people like this all the time, only report first of all what's been seen, rather than, oh, we can't see uterus or this and this and this, because this can stick for quite some time with families, even if the structures are there in the end. Go for serum, plasma, and urine safe before you start treatment, but there's also some bit to tailor this stuff according to diagnosis, because if you look at all those, or probability, because otherwise we might end up with a blood transfusion, taking all those bloods in the first go. The other bit is if you have, for example, have someone with 46XY, then it's very unlikely. So it's very unlikely to have someone with 21-hydroxylase deficiency. It might be worth prioritizing hormones, etc. Okay, if we have a look at male sex development, then this happens all very early on in life. And this is a simplification. I'm really sorry, but it is a bit complicated, but I haven't invented it. It starts off very early on with a bipotential gonad, and under the influence of some transcription factors, and you need a Y chromosome or SRY and some other genes like SOX9, WT1, and SF1, we have the development of fetal testes with fetal Leydig cells and Sertoli cells. Now, this is sex determination. Then the fetal testes may enter Müllerian hormone, and this leads to regression of the female or Müllerian structures. The testes synthesize testosterone, which leads to development of the male or the Wolffian structures. And then testosterone is converted by 5-alpha-reductase type 2 to dehydrotestosterone. You need that for the development of the external genitalia and the virilization of the external genitalia. And that bit is sex differentiation. On the other hand, if you have a problem like hypospadias or other forms happening very early on here, that gives you an idea that you have had a problem in the first trimester. Whereas if you have a micropenis fully developed, that's a problem most likely happening at another time point. This is illustrated here. There's a very nice review which has recently been published by Rodolfo Ray and colleagues, looking at different presentations of, or summarizing this, the development of physiology and clinical presentation of hypogonadism. And looking here, illustrating in the first trimester, you have your Sertoli cells and Leydig cells, AMH and androgens, and the development of the external genitalia. And if you have a problem here, you have ambiguous or atypical genitalia or a female genitalia, if you have lack of it. And then later on, that's the time where you have a micropenis or cryptorchidism or small testes. So it really depends where when the hit occurs, what kind of clinical presentation you've got. I'm not going to go through this whole thing here. And interestingly, it's also to review when you do your test and take your bloods. It's from the same paper, but it's probably one of the nicest reviews in quite some time, that you have this steep rise of various hormones, including AMH, inhibin B, and testosterone, really high testosterone levels very, very early on. And then also mimicked only later by the rise of LH and FSH, the drop after birth, and then this period of mini puberty about 6 to 12 weeks after birth. And this is also something where we try to take bloods quite often because we have a natural rise in this. And then later on, all those other changes here with inhibin levels first going down, then going up in boys, and AMH gradually decreasing. Right, and just to have a few thoughts, if I see someone with one of those conditions, what I think about is, and this is not a complete scheme, but I would think about the karyotype. So what have we got? 46XX. But what do we need if someone with 46XX? Probably a blood glucose, user needs N17 or HP. As I said, it's not incomplete, but this is just something to bring things in order, because the likelihood is that this is someone with congenital adrenal hyperplasia, 21-hydroxylase deficiency. And then save some stuff for urinary analysis or plasma analysis before treatment. It becomes far more complex if the karyotype is other than 46XX. You might need an AMH to get an idea about the testicular function. We can discuss it probably for hours. If you need an HCG test, I have to say I'm not a great fan of it. Urine analysis for proteinuria, I come to this in a second. And then there are probably various forms of imaging or genetic analysis, and one can discuss the timing. The key is here, why why do you like a short synapse test in all those kids? It's not only because I have a really interest in the adrenal gland and cortisol, but the point is there's no condition if you have someone with atypical genitalia and a normal cortisol response who needs really intensive further monitoring, because there's no condition having androgen deficiency and mineralocorticoid deficiency, but your glucocorticoid replete. So I think this is a really good test to de-escalate things and taking blood tests every day. Because if cortisol replete, you can de-escalate, and there's no 46XY with mineralocorticoid deficiency if your cortisol replete. And there's loads of other more algorithms. There's a good review published in 2019. I'm not going to go through this here, but give you a few thoughts on that, how a diagnostic works. I mean, there's quite a few different algorithms that have been developed. Going back to this patient, and this is something we've done a HCG test, and this is quite a few years ago, because I'm not doing many HCG tests anymore, I have to say. And the reality is, quite often in babies, you have insufficient samples, then you get some results here with a testosterone that goes significantly up. Dehydrotestosterone, there's some measurable stuff, and you have this ratio of testosterone to DHT, and there's various ratios have been published, either above 15 or 20 or 30 in small case series suggesting 5-alpha reductase deficiency. On the other hand, I've seen quite a few patients who have raised ratios who don't have 5-alpha reductase deficiency. I'm not really sure that this really predicts stuff really well. So the question is, how good is the diagnostic sensitivity and specificity? Due to time, I can't give you that, but I personally, from personal experience, think it's not a fantastic test. And when do we need to use a HCG test? And this is the first line test. And I can tell you how we use it. We use it if we want to see if there is gonadal function, yes or no, but not to stratify further diagnostic processes. So going back to this patient, and in all honesty, we had the genetic results earlier back than the biochemical results here, and that's a proven case of 5-alpha reductase deficiency. And then most people nowadays, probably as a baby, would raise those kids as boys. So because there's also increasing evidence that sex assignment and Ken's karyotype probably doesn't happen very often anymore, and it's really a question where you work. But as I said, in our practice, that's probably not happening very often anymore. I'm giving you an example here. We treated him with androctin gel, which is DHT gel, and it's really powerful stuff. In particular, with someone with 5-alpha reductase deficiency, that gives usually relatively good penile growth. But the question is also, which we could discuss in another context, this is an irreversible intervention, and are you allowed to do this? And there's interesting discussions going on at the moment. However, I would still carry on doing this stuff. Okay, to give you a few other examples and a bit other flavor of diagnostic pathways, so this is someone who has been referred by a gynecologist, raised testosterone, really high testosterone, couldn't believe it in the first time, so this is good girl male levels, and LH and FSH not very high. So this individual was born at term, mom had menarche at 12 years, parents were distant cousins, and there's a mum's sister presenting with a similar history. And this young woman is very tall. And to cut a long story short, so this is again, there's there are masses down in the left labia majora, and that's indicative of testes and no breast development, etc. And pubic hair, I'm not sure if any of your patients still has pubic hair, because they're all shaven nowadays. To cut a long story short, this is someone with 46XY karyotype. Uterus wasn't visualized, and this is also someone with 5-alpha reductase deficiency. It could be also, it's less likely to be CS. We can discuss that. We can discuss that probably afterwards. With a proven mutation for 5-alpha reductase. So it's two different presentations. So if we, and also for this patient, so how do we explain this and what happens And what's the thought process for the diagnostic process? Because we have this chromosomal sex with 46XY and XX, and as a next step in doing sex determination, the development of the gonadal sex due to testis determining genes, or testis suppressing genes, probably less ovarian determining genes, and then developing a phenotypic sex. And something what's quite clear is that what's been widely recognized, there's also the idea that the brain has an idea what sex this brain thinks it is in. What I tend to explain is not normal chromosomes, but this is that there are also people like in this person who have 46XY chromosomes, but then develop as females. It's just something slightly off this talk. When explaining this, and I use this slide also for patients and families, is try to explain it without using normal male and female. There's obviously loads of stuff that can happen in this bit. I'm not going to go through this in detail, but it's just to illustrate and preparing you to the next few points I would like to make, because it's quite a few genes involved in 46XX and 46XY DSD. So the problem comes here that only 40 to 50% of patients with 46XY DSD have a definite diagnosis. So that's a bit tricky. And even with new technologies, and I'll give you a few examples here. So, and there's quite, as I said before, there's quite a few genes. So this is genes associated with 46XX DSD. Now blocked out, sorry. Then with gonadal disorders of gonadal development or gonadal dysgenesis, with androgen excess, with abnormal androgen synthesis, as I said, sorry, I'm not going to go through it, okay, with other bits and bobs, okay, or Muller-induced anomalies. So this was a review we've written as a guidance document, how to do the genetic diagnosis. This is now 2 years old. And I'm not saying it's hopelessly outdated. So with 62 genes with 46XY DSD, 61 with 46XX, and there have been a few more since. Okay, so the point is, if we want to do an analysis step by step, it might take an eternity to analyze all that stuff. Now this is patient 3. I'll give you an example. So this is a newborn with penoscrotal hyperspadias with a gut phallus, cryptorchidism, bifid scrotum, normal kidney and heart ultrasound. And I come to that point in a second why I do kidney and heart in everyone. Karyotype 46XY, AMH is borderline, just below the normal range. So that's still normal. LH, FSH, normal, testosterone is appropriate for age. The male sex assignment planned 2 to 3 stage corrective surgery. At 8 months, this chap is short of breath, has a failure to thrive, has a dilative cardiomyopathy, has massive hypertension, and has bilateral Wilms tumor. And we changed the genetics, and he has WT1 splice mutation. And this is something which is interesting and worrying, because what we've classically having in textbooks is WT1 or Wilms tumor mutation are classically described being associated with Weger syndrome, Dennis-Stress syndrome, and Fraser syndrome, which are all you will not be able to miss them because those kids are so ill. Okay. However, in contrast to mice, there's no adrenal problem in humans, whereas in mice you have also adrenal problems. What's happening now with WT1, however, there's an increasing number of phenotypes. Okay, and the question we're currently discussing is when, who, and in whom to test. Because we can't test everyone with penoscrotal hyperspadias, or do we need to test everyone, or do we need to test people with cryptorchidism, etc.? So there's a huge spectrum of manifestations, in particular when you turn it around and come from the Wilms tumor side. The bizarre thing is now that the phenotypic spectrum is expanding. So there's now WT1 variants in a specific area of WT1 where you have people with 46XX karyotype who develop into males and develop a DSD. So it's just exactly the opposite effect from the classic phenotypes. And they have no, until now, they have, in those guys, no major renal problems have been reported. Some of them had diaphragmatic hernia. Then there is another bit you might have heard about SF1, and SF1 classically was described as a gene with sex reversal and adrenal insufficiency, and then there's a zillion and another 2 phenotypes with male and female infertility and other problems in gonadal dysgenesis. And here the same, partial gonadal dysgenesis, testicular DSD, over-testicular DSD. So an expanding spectrum of phenotypes. And something, a new kid on the block, DHX37, which has been described in complete gonadal dysgenesis, partial gonadal dysgenesis, and testicular regression syndrome in the same frequency, probably occurring as mutations in SF1. So that's something to think about. But to drive this home now, the traditional diagnostic pathway, on probably some people or quite a few people are still doing it this way, goes with clinical phenotyping and diagnosis, looking at the karyotype, stratified then biochemical analysis, and then stratified genetic analysis. And that takes simply forever. So what we've done since quite a few years is do the clinical phenotyping, biochemical analysis, and genetic analysis all in parallel and try to get to a management decision. So have it standardized, try to have this standardized clinical assessment and look for associated problems, steroid profile. This is not complete, but AMH, inhibin B, and function test potentially, but then also depending on the presentation, have chromosomal analysis, CGH analysis, targeted assays, or whole exome sequencing. But there's one problem with the whole exome sequencing, which is all great. So I'll give you an example of someone I've recently seen. Ex-prom, 29 weeks old, non-syndromic, some complication of prematurity, but catching up really well. Testosterone relatively high, but to be fair, this was measured in a non-specific assay because on repeat, there's no steroids around. And what we've got here, okay, is we got a bunch of different genes of variants of unknown significance, and all of them could probably cause a little bit of a problem. Some of them are less likely being involved in it because developmentally, this child is completely normal. It's just something, if you do next generation sequencing tests or genomic analysis, you might get a huge bunch of stuff which is not entirely clear. I think I'm on time. Let me sum this up and conclude. So I think what's important is that we need to be clear what questions we want to answer and when we want to answer them. We have not stopped, but significantly reduced the number of invasive stimulation tests and don't use them very often anymore, and do quite a bit of stuff during mini puberty, and tailor the approach, prioritize test to presentation, save biomaterial in particular before you treat and intervene. Sorry, I'm not sure. My mouse is very sensitive, sorry. The evidence base, however, for several aspects remains relatively weak. And that includes sex assignment, third gender, etc., etc. And I'm not sure how diagnostic processes can help with it. However, I think the important bit is that the genetics is really integral to or one of the key bits of the diagnostic process. And we need to have some careful assessment of variants. Are they pathogenic? And then there's a significant proportion of non-syndromic 46XX DSD. Could this be multifactorial, and might we not get a conclusive answer? Thanks for listening. And I need to stop now. Apparently, I'm also moderating now, and I think it's Erica who is, sorry,
Yes, I'm right here, ready for presentation.
Okay, so we've sorted it all. So Erica Vandenacker is head of Pediatric Endocrinology at the Sophia Children's Hospital, where we are all at the moment in the Netherlands, apparently. And she's going to present on how to assess adrenal reserve in a child with therapeutic doses of glucocorticoids. I'm really looking forward to your talk.
Thank you very much. I will first start to share my screen and make sure that everybody can see it. Can you confirm that, Niels?
Yeah, it looks good. I think
Yeah.
if you click on presentate, yeah.
Wonderful. I put it on presentation mode.
Great. Okay, I've got it.
Great. Well, welcome everybody to this session on adrenal reserve after glucocorticoid treatment. My name is ERICAN van den Akker. I'm a pediatric endocrinologist in Sophia Children's Hospital and presenting from here. I've been in this field for more than 20 years now, and we get a lot of questions on this subject on our consultancy phone. So I hope to bring this further for you, this information, so you can answer those questions, a lot of them yourself, next time. What will I be talking about? I'll be talking about adrenal insufficiency and specifically the type after use of glucocorticoid treatment in children. And then we will discuss who actually is at risk for that type of adrenal insufficiency. And when a patient of yours is at risk, how do you assess the cortisol reserve? Which test do you use? In which patients? And when do you test? And if you have the test results, then what are normal cutoff values? So a lot of patients are treated with glucocorticoids. This is the case worldwide. If we look at the Dutch survey, which is done nationally alone, in a population of 17 million people, around 1 million systemic glucocorticoid users are present, and there are almost 6 million prescriptions yearly. And that's not specific for the Netherlands, that's worldwide. So there are a lot of patients on glucocorticoid treatments. So what type of adrenal insufficiency are we talking about? We know there are several types. First, there is the primary adrenal insufficiency, which is a defect at the level of the adrenal itself. And there is secondary adrenal insufficiency at the level of the pituitary gland. And the second one is the case when you talk about iatrogenic adrenal insufficiency in the case of glucocorticoid treatment. How does this work? Well, this system is under the regulation of a feedback system. So the pituitary gland produces ACTH, and that stimulates the adrenal glands to produce cortisol. That's the endogenous glucocorticoid of the human body. This cortisol exerts its effects in the tissues, but it also exerts an effect on in the case of a feedback system at the level of the pituitary. So when the level of cortisol is enough, it gives a signal to the pituitary to stop producing ACTH. That's the physiological situation. But what happens in the case of synthetic glucocorticoids? For example, when you give dexamethasone. Dexamethasone travels through the blood, exerts its effects in the tissues, but it also gives an effect at the pituitary level to give a negative feedback. So the dexamethasone suppresses the endogenous production of cortisol in the body. So normally the body in a physiological situation, it produces cortisol in a daily rhythm. This is important to keep in mind when you start testing in a child. Normally you have the peak levels early in the morning after awakening and a nadir during midnight. What happens if a child gets sick? Those levels increase. And here you look at the dotted lines. When somebody gets ill, the daily rhythm is gone and the levels are increased and especially are at around the same level during the whole day. So what is the risk if somebody has adrenal insufficiency? Why do we make such a big fuss of it anyway? Well, it's because if you are not able to increase your cortisol levels during illness, you have the risk of adrenal crisis. And adrenal crisis is a life-threatening situation. Patients with unknown adrenal insufficiency who get ill, they can become critically ill because they cannot keep their glucose level up, and they cannot regulate their cardiovascular, they get cardiovascular insufficiency. So it's important, if you are a prescriber of glucocorticoids, it's important to know which of my patients is at risk for this. And that question is a bit more difficult to answer. There has been a lot of course, there are a lot of different types of patients, types of diseases, and types of glucocorticoids. This review gives a very nice overview of how big the risk is per patient in certain types of administrations. For example, what you see here is glucocorticoid by route of administration and the absolute risk, not the relative risk, but the absolute risk of adrenal insufficiency in those patients. This is a review on adults, I should say. We do not have a review like this in children. But what you see here is what we all know, is that when you give it systemically, orally, then the risk is quite high. In this case, almost half of the adults have suppressed adrenal glands. But what is sometimes less well known is that also the other routes of administration give a risk of adrenal insufficiency. For example, by inhalation, most inhalation corticosteroids, in the case, for example, in asthma, most patients do not have systemic effects and do not have adrenal insufficiency. However, there is a small percentage, around 7, in this case, around 8%, that do show depressed levels in ACTH tests or in adrenal tests, for example. And especially when you give multiple of those forms, for example, inhalation combined with intranasal, combined with transdermal, you should be aware that this can be the case. The second thing that you should look at in your patient is dose and duration. In this study, they looked, divided the patients in those who used it short term, shorter than 1 month, or long term, longer than 3 months. And here you see the risk on adrenal insufficiency. In short term, the risk is very low, only 1% of patients. But in long term, the risk is almost 1 in 3. So it means the higher the dose, the longer you use, the higher the risk of adrenal insufficiency. So why is there this difference? Why does one patient suppress and another does not? Well, the reality is that individuals differ. They differ in the way they metabolize the glucocorticoids, and they differ in their sensitivity to it. And I personally very much like this study, for example, which showed very beautifully the immense difference between people in the half-life of, for example, in this case, hydrocortisone, which can be measured in their blood after taking a dose. And here you see that some peak very early after taking the dose and have a slow decrease, and others do not have such a high peak and have a fast decrease. And this the half-life can differ. For some patients, it is 4 hours, and for others, it is maybe less than an hour. So we should take this into account when we look at our individual patients. So there is not a general guideline on this subject, but from literature, there are several recommendations to make on this. All patients that use corticosteroid therapy are at risk for adrenal insufficiency, and the clinicians who treat them should inform their patients about that risk and should inform them about which symptoms they should be aware of and which they should note. And if they show symptoms or if they are at risk, then the clinicians should consider testing in these patients, especially after stopping the glucocorticoids, especially after a high dose or long-term treatment. Okay. So now I will discuss further how you do that in clinical practice. I first should specify that I'm talking about children from 0 to 18, not adults, with iatrogenic central adrenal insufficiency. There's no specific guideline on this. There is a guideline on primary adrenal insufficiency, which can be helpful on some of those subjects. And we are talking about treatment that has been for more than 14 days in pharmacotherapeutic, so supraphysiological dosing. And that is the first thing that we should address. So what do we mean by physiological dosing? For hydrocortisone, which is exactly the same as the endogenous body cortisol, the physiological dose is around 10 milligrams per square meter per day. So if you use a different preparation, synthetic, for example, prednisone or dexamethasone, then you should first calculate what is the hydrocortisone equivalent of this treatment. And here you see a table in which you can calculate that. For prednisone, usually the effect is 4 to 5 times stronger than hydrocortisone, and for dexamethasone, depending on what type of outcome parameter you look at, it's around 30 to maybe 60, and some think even higher effect than hydrocortisone. It's really much stronger. So before you start testing, first you should say, okay, this patient has been on a supraphysiological dose. How do I get to a normal situation? Well, very helpful in this is the Dutch guideline, which was published quite recently. And they really searched the whole literature to answer this question. And I must say there is little literature on it, but there is a very good suggestion on expert-based opinion how to address this. Step 1, you taper the glucocorticoid dose from supraphysiologic to a physiological dose. That's the first step. Step 2 is then to stop the evening dose, stop the afternoon dose next, and then have a morning dose only. Why? Because the physiological daily rhythm has a peak in the morning. When that goes well, then you stop the whole use of glucocorticoids and you give a stress schedule only. Of course, the next question is how fast do you do these steps? I do not have a specific answer for that. That is because it differs what type of patient you have, how high was the supraphysiological dose, and how do they feel when you taper it. So keep looking at the patient, how the patient feels before you make the next step. And usually this will take weeks and sometimes months and sometimes even a year. So when you have stopped the synthetic glucocorticoids, then you can start thinking of how to assess the adrenal reserve. How do we do that? Well, pragmatically, you can choose to first screen by doing a morning cortisol test, either in blood or saliva. Why? Well, because sometimes this already gives the answer whether there is enough adrenal reserve basally and in the situation of sickness when you need higher levels. Here you see a study that showed random measurement of morning cortisol after awakening. This is again in adults, but we think it's about the same in children. And here you see randomly, if you measure in the morning, then spontaneously about 1/3 of patients, every dot is a healthy control. About 1/3 of healthy controls already has a cortisol level that is high enough, above 500, to make sure that your levels are high enough in case of stress. So those people don't need further testing. Although still 2/3 of those do not have peak levels above 500, and those might need further testing. You can also do these tests at home, for example, by saliva measurement. We very much like that for children because they can do it in a stress-free situation at home, right after awakening. And but then, of course, you do need to know what is the cutoff for that. Well, luckily, saliva has a very, very high correlation with blood levels. So the cutoff in our case for a regular immunoassay is above 20. That confers to the serum cortisol of above 500. So, but let's take the patient that does not have a spontaneous peak that high. What to do in those cases? Well, that's always difficult. Which function test will you use? Well, in adults, they mainly use golden standard tests, which are the insulin tolerance test or the metirapon test. Those tests are regularly not used in children. Why? Because they are more at risk for severe side effects of these tests. Usually the SYNAC-10 test or the ACTH test are used. But there are two different kinds of tests. One is the low dose test and the other is the high dose test, or also mentioned as standard dose test. They use different doses of ACTH. There is discussion also in literature which test to use. I think you can use both. You can choose yourself. What does the literature say about this? Well, the international guideline, for example, the guideline of the Endocrine Society on primary adrenal insufficiency prefers the standard dose test. But others prefer the low dose because that in that case, the ACTH is more in a physiological level. Here you see in the Dutch guideline, they extensively looked into literature on what is known on the sensitivity and specificity of these tests. And they compared it to the golden standard tests. And here you see that it depends a bit, of course, on which study you look at, which type of patients, but mainly the predictive values are not that much different of the low dose and the standard dose. So there is no evidence which prefers one of those two tests. You can use either. The next question is, when you decided to test, when are you going to test? So after stopping the glucocorticoids, you have to find the right timing. And it's also a bit up to you and in discussion with the patient. How sure do you want to be that somebody doesn't need stress dosing anymore? Well, we usually, and that's also in the Dutch guideline, it was an expert-based opinion that you can consider testing 3 months after stopping glucocorticoids. In that case, around 3/4 of the patients their adrenal insufficiency has resolved. And that's nice because then you can stop the stress schedule. If the adrenal insufficiency is not resolved, then you can consider retesting every 3 months, or you can consider after a year, in which case almost all patients have a resolved adrenal insufficiency. So what do we do with the test result? Well, of course, it's difficult to give specific cutoffs for your lab, but in most labs, immunoassays are used. And then the cutoff of around a cortisol of above 500 to 550 is usually considered sufficient. For example, our lab uses the Roche immunoassay, which is also used a lot internationally, and that has a little bit lower cutoff of 430. So in summary, what are the take-home messages that I would like to give you? First of all, iatrogenic adrenal insufficiency is not rare, and the risk is definitely associated with type, dose, and duration, but it cannot be predicted by that. So it means that you always have to be aware in every patient that you use, in which you use synthetic glucocorticoids. You have to inform them about this risk, inform them about possible symptoms and look for them and ask for them, and consider testing 3 months after cessation of the glucocorticoids. You can do that by screening, a morning cortisol, or in addition, the ACTH test. And the peak should be around above 500, depending on assay. Thank you very much for your attention.
Thank you very much for really interesting and comprehensive talk. Shall we move on to the next speaker, who's Dr. Theo Sass, who's also from the Sophia Children's Hospital, and who's going to give a lecture on Turner syndrome diagnosis, therapy, and more. And then afterwards, we are there to answer questions. Thank you very much.
It would be good that you unshare your screen, ERICAN, please.
Yeah. Sorry. I think now it's okay. Is that correct?
No, not yet.
Yeah.
Yeah, I think it's the case. So share screen. So I think I've shared my screen. Thank you for the introduction. This is Amsterdam. It's a beautiful city, but today we are not there. And we are working in Rotterdam, just a few kilometers, you can say, to the south. And Rotterdam is a new city, at least it's rebuilt after the Second World War. This is my disclosure. And my interest in Turner syndrome started in the previous century, the last century, by working for 5 years on my thesis. And I had the opportunity to be involved in the study about oxandrolone in growth hormone untreated girls in Turner syndrome, and we have done a follow-up study. And what we have learned is that Turner syndrome is more than growth and puberty, and of course the hormones are very important, but there are a lot of other factors which are important in Turner syndrome. And this is a guideline, a clinical practical guideline, and I will use this in this talk. We have made this and we published this in 2017. And what we can see is that over here there are 70 pages. So we have tried to make some tools and with the idea to improve the lives of Turner individuals and to decrease the morbidity and to prevent early death. And that's important because still women with Turner syndrome die about 15 years earlier than their healthy peers. So we have to do a lot. Of course, you could read the recommendations in the first pages, but perhaps that's a little bit boring. So we will use a story of a girl. She's 4 years of age and she comes to your outpatient clinic with short stature. She has no dysmorphic signs. The parents are not that tall as well. But you have to rule out, even when there are no dysmorphic signs, that it's Turner syndrome. And in her case, she has Turner syndrome. And she's growing on this line. And that is not the line for healthy girls, because it's this one, but it's on the Turner syndrome line. And we'll come back on this. In most girls, the diagnosis is made in childhood. That you can see over here. That's a Danish study. But you can see even in the 45X girl, 45X individuals, that some diagnoses are made later in the year. So it's important that we look very carefully and think about this diagnosis in the different phases of life. And we can have the diagnosis before birth. Turner syndrome is not associated with higher maternal age, but of course, when you do a karyotyping because of high maternal age, you can find it, or due to other echography abnormalities. There is a new way to look for, at least for trisomy, and that's the NIPT test. I think often most people know that. It's searching for circulating cell-free DNA in pregnant women. And it's working with trisomy, but it's important to know that it's not good for monosomy. And there are a lot of factors, and I'm not the expert of it, which influence this test for monosomy. So if we have a positive cell-free DNA screen for 45X, please, it does not mean that the fetus has Turner syndrome. The diagnosis can be made after birth, just after birth, when the hand or feet are swollen, or when there is a congenital heart abnormality. And there are some studies about neonatal screening, and what I know is that there is no country who's doing at this moment a neonatal screening for Turner syndrome, but it will come, I think. But you can imagine that just karyotyping is a lot of work to do. So there are thinking about several genes which could be done, and to search for whether there is Turner syndrome, or you could do a whole exome sequencing. We will see in the next years whether we will succeed in doing this. When the girls are a little bit older, of course, a short stature, like in our case, or there are dysmorphic signs, and perhaps there will be new ways just to look very carefully to Turner syndrome. When the girls are older, it could be short stature or no puberty, or when the women are older, it could be that it's infertility or short stature or hearing problems. So if you have a girl or woman with only one of these signs, or at least two, you have to think about it, that it could be Turner syndrome. And then you have to do the karyotype. And if you have a complete or partial absence of the second sex chromosome, and you have one or more typical clinical manifestation, then we can say this is Turner syndrome. If you have a very low-grade mosaicism, then it's not so easy. And we decided with the guideline that we did not have a specific lower limit. But you can imagine that in some girls who do not have any problems, that you do not all the things that you would do for screening of health problems as you would do in a 45X individual. And there are some cases which in X chromosome is involved, but we say, no, this is not Turner syndrome. And that's particularly because older women, healthy women, lose an X chromosome when they are becoming older. We do not exactly know how the absence of one of the X chromosome really leads to all the symptoms which we can see in Turner syndrome. And there are some studies done, and we're searching, of course, everybody for which part is responsible for the things we see in Turner syndrome. And this is a review from the group of Graafholt, and showing that perhaps it's not only missing X, but there are other phenomena, other genetic things which will result in the phenotype what we see in Turner syndrome. So going back to our patient, fortunately there are no problems, no other problems in this girl. Most of the times there are ear problems and feeding problems, but in her case not. She comes to your outpatient clinic because of short stature, and they ask, is it possible to start growth hormone? Why would you start? Of course, first of all, you have to explain to the parents what you expect when you don't give growth hormone. And therefore you need the growth curves for girls with Turner syndrome, like here the Dutch, Swedish, Danish curves of untreated girls with Turner syndrome. And this paper, a review paper from 6 years ago, shows that there are different growth curves in different countries. So we know if you are growing on this line, this Turner line, you will follow this line until the end. And of course, we do not exactly know where it ends, whether it's here or here, but it's a quite reasonable prediction method. And with growth hormone, we know now for several studies that it will increase your height. That is clear. But how much? There are quite a lot of differences between studies, different designs, different dosages, and different start ages. And we can see over here that if you start early with growth hormone treatment and you are treated for several years, it is possible to have an adult height which is more close to the normal heights for healthy girls, even when you use a standard dose. In general, we say when we talk to our patient, they are quite happy that they are not the shortest anymore, or at least they are less short than what they were before. The strange thing, but that's not typical for Turner syndrome, is that if we do health-related quality of life studies, we cannot find easily the positive effect back in those studies. And there seems to be a discrepancy between when you talk to the patients and the support groups and when you do the studies. And the question is that a quality of life test, are they working well for short stature or Turner syndrome? And is it really no positive effect, or is it not big enough? Or is it impossible to pick it up, the positive effect? So in general, I know that most patients, it seems to be beneficial for them, but of course you have to realize it's a treatment option. It's not a life-saving treatment. So you have, of course, always to discuss this with your patient. And most girls and parents will choose to start with growth hormone treatment. But there are some girls, this is an example of a growth curve of a girl who has tall parents. She's growing on this line, and what we can see is the normal growth diagram. She has quite good growth, and this is the same girl on the Turner line. You can see that she follows the line. So this girl didn't receive growth hormone treatment, and so that is a choice. And you can imagine that she didn't choose for this because of the normal height. Are the side effects of growth hormone treatment? We have done quite a lot of studies and others as well. And we can say in general, it's reassuring when you look to all the factors which could be influenced by growth hormone treatment. However, we have to realize that the clinical trials are powered particularly for growth, for efficacy, and not for the low frequency side effects on the long term. So we need other studies as well, like the Sophia study. And in general, we can say it is reassuring, but we need this for the long term as well. So do we start now? She's 4 years of age, this girl. Yes, it's a good age to start, and particularly because you would like to have a long periods, years, that he can catch up growth and that she can grow further. So that's a good age to start. The starting dose, in the Netherlands at least, we give, for us, it's an almost double dose compared to the growth hormone deficient. But with the growth hormone deficient patient, we give in general a little bit lower dose. But this dose seems to work and not the lower dose. So Julia started with growth hormone treatment in this dose. And what we can see is she's growing here. On the left side, you can see it. We see her every 6 months, 4 to 6 months. And we measured every year the IGF-1. And the IGF-1, it's not an easy discussion, because we would like to try to keep it lower than the +2 SD, or if it's not possible, lower than the +3 SD. But we do not have evidence that a higher level is negative on the long term. We know that there's an association between high IGF-1 levels in the general population and cancer, but we do not know, there are no studies showing that growth hormone treatment with high IGF-1 levels has problems later on. But we don't want, because it's not a life-saving treatment, we would like to be careful. So she catches up further, that's nice, but then it declines a little bit. And of course, you have to look for celiac disease, hyperthyroidism, and of course, good compliance. In her case, that's normal. And then we have some things which we could choose what to do. First of all, could you increase the dose? And what we know, and that's not for every indication who receive growth hormone, is that in Turner syndrome, at least, it works that you could give a higher dose, and that will end up with a higher adult height. So that's possible, but of course it has to be possible in your country to give it, and you have to look to the IGF-1 levels, perhaps even more. Could you add oxandrolone when it's available in your country? Again, in Europe at this moment, it's not easily or not available. And we know from studies that it works. It could add extra centimeters in addition to growth hormone. And this is published, these 3 studies are published almost 10 years ago, showing the effect and showing that in general, it is safe to give oxandrolone. There are some side effects. These are in general mild and transient, and we talk about virilization and slowing down a little bit the pubertal progression. But yeah, it's not available at this moment. Should we add an ultra-low dose of estradiol, not in puberty, but before puberty? Could that help? And that is the idea, and these are 2 studies showing the estradiol levels before puberty in boys and girls, healthy boys and girls. And what we can see that even in the prepubertal girls, in healthy girls, the estradiol is higher. So perhaps, and we know in Turner syndrome, there is most of the time there is ovarian failure. Perhaps it could help to give them a very low dose. And this is the study of Judith Ross, which is published 10 years ago. She gave ethanyl estradiol. That's not what we advise nowadays, but it was the moment that she gave, in addition to growth hormone, even before the age of 12, in a very low dose. And she decreased the dose when there was breast development or acceleration of bone age. And then she introduced puberty with a higher dose of ethanyl estradiol. And she showed that change in height SDS was the best when you combine it with the very low dose of estradiol. But we have said in the guideline that is only 1 study that we give ethanyl estradiol. It's not done with 17-beta estradiol, the natural estradiol. And you have to be very, very careful not to induce puberty too early or to decrease adult height by increasing the, you could say, the acceleration of bone age. So going back to Julia, we decided to give a higher dose, and you can see that she was growing well. But what I said before, there are other problems, and that's what we know. It's not only about hormones. There are also social problems with friends at school. She has problems with planning, schoolwork, and the gymnastics, particularly when they're doing ball sport, it's not her favorite. And that's what we know. We know that Turner syndrome is associated with a certain neurocognitive profile, and that can have a negative effect on several domains. So what we have said in the guideline, that it has to be the neuropsychology and the behavioral health science, it has to be integrated in the care for a Turner woman. And you have to screen for problems, and these are all important for the psychosocial well-being. So we have the opportunity in other expertise center in the Netherlands that we have a psychotherapist, a physiotherapist, and a psychologist. But when you don't have that, you can use the guideline, because the guideline addresses the problems and shows the different domains and how to test it. So even when the experience is not there, you can use the guideline for this. But there are other things. Fertility preservation, parents are reading things and they think, okay, Julia has mosaicism, perhaps there are some oocytes left and we could freeze them in. That is the idea, and this is a streak ovary, and that's the risk of, perhaps when you wait too long. Oocyte cryopreservation is possible, but you need ovarian hyperstimulation, and these things are not so easy for 12-year or even for 15-year-old girls. And most girls will be young women, if they think about it, to have the hyperstimulation. So in this case, it seems not to be suitable for Julia. There is a French study and a Dutch study picking out an earlier time in childhood a part of the ovary and freeze it in, with the idea that you could put it back several years later. But that is only a study, and we do not know whether that will work. And of course, when she's 11 years of age, she would like to have breast development. Should we start it now? And if we look what's normal, this is healthy Dutch girls, is that B2, TEMA B2 stage is reached when they have, for half of the girls, when they are 11 years of age. So that seems to be a normal age to start. And it's important, and I think it's our duty as pediatricians to explain that it's not only for breast development and to have a cycle, but it's so important that the estrogens will be taken for the rest of their lives until they are 50 or 55 years of age, because of so many positive effects on the body. So we have to explain it. So if the gonadotropins are elevated and the girl is 11, 12 years of age and there is no breast development, you should start with a very low dose of estradiol to make it age appropriate. What to start? It depends on your country, what's available in your country. And when you look to the transdermal patches, the lowest doses, you find just like this, for example. And even then, you have to cut it, and we'll come back on this. There is an estradiol gel. It's not available in the Netherlands, for instance, and it can be very nice, but it's not very precise in the very low dose. And of course, there are pills, and there are pills for adults, but the dose is too high, and there are pills for children, and these pills are not always in every country available, unfortunately. So in the Netherlands, we can use this. I'm used to give transdermal nowadays. Of course, I have to ask what the patient wants, and not only at the start, because most important of everything is that they have to use the estrogens. And of course, I have to explain it, how to do it. That's very important. And of course, because you will cut the patch, if you are going to use the patch, it is not, you don't want to have problems with cutting the patch. So it's important that you have a national protocol for it. The cost of the patches when you cut it is lower, far more lower than when you use the estradiol tablet. But most important is what's best for the patient. Is that transdermal or is that oral? And it seems to be that it's more transdermal, but we didn't have done any study from the start of puberty until menarche comparing the different regimes. We have only circumstantial evidence saying it's more physiologic. You have not that high dose of estrogens, and the chance of thrombosis is lower. That's what we have. And this is a quite new study. It's only one study of Nelly Mauras from the United States, and she She said, when you give for 1 year oral estradiol, it will result in a substantial accumulation of unphysiologic genotoxic estrogens, metabols. You can see them over here, which is higher with oral compared to controls, healthy controls, and to transdermal. So this could be a reason to think about more to give transdermal, although we do not know exactly what the consequences will be of these estrogens on the long term. So there is some evidence, we say, for transdermal. And if you use transdermal, please use a matrix system because you have to cut it. This is what is done in the plant of the manufacturer. They cut it in parts, and this is the patch. And we have to cut it further into small pieces. And is that possible? Yes, that's possible. We have showed it in the laboratory. This is Carina Ankerberg. She has done a test. She cut it, the patches, and she stored it at different temperatures and to follow it for a month, whether the estradiol is still the same. These are the patches. And this is the difference in estradiol concentration during the storage time for a month for the 4 different patches. And what we can see is that even at the higher temperature and the room temperature, at least in the Netherlands room temperature, that you can see that it's stable for almost all 3 patches, not for this patch, during storage. So it's possible to store, and as long as we do not have patches for children, it's a safe way to do. So I explained to the patient how to do it, to Julia, and we started. But how to do the pubertal induction, we do not have any studies comparing the different schemes. And of course, always you have to individualize, and starting with a low dose, and then you need your time because normally B2 to B5 takes time of 3 years. We have published last year, and you can say a more consensus idea, proposed modern strategy for the oral 17-beta estradiol in 4 years, increasing your dose depending on your weight. And for the transdermal, for the different patches, 25 and 50, for year 1, 2, and 3, and 4. And this is the weight and the part of the patch starting overnight. So we started in Julia, and we increased the dose every year, 6 months. This is the growth. And we added progesterone once breakthrough bleedings occur, or after 2 years. And we give it the first 10 days of the month, and further increasing the estrogen dose to a patch 2 times a week. And of course, transition, and the moment now to think about transition is rather late. You have to start earlier. You have to talk with your patient, of course, because I think it's a very important moment that that the care is done by the pediatrician, but the rest of their lives, they are not by the pediatrician anymore. So we have to prepare them for transition and to be an adult. So you need to know whether they are ready for transition. We need a transfer summary, particularly when they're going to another hospital. And of course, they have to take care for themselves. And these are examples which are used for these things. But there are other things. She wants to run the Rotterdam Marathon. And I think that's very beautiful that she would like to do it. But is it safe? Do we know that? And that's very nice for the guideline. They have a sport participant chapter as well, because we find it very important that they participate in sport. But of course, you have to look very carefully to the aortic size. And that's something we know that we have to do it. And when we don't, not in relation to sport, it is an advice what is given, and you can see that in the guideline as well, how to do the aortic size echography or MRI, etc. And that is all thought about it, try to avoid aortic rupture, which is a problem in women with Turner syndrome. But there are other cardiovascular diseases, and I told you before when starting that they die earlier than their healthy peers. And there's an increased risk of all these things, and perhaps there is a vasculopathy which plays a role already young. at a young age. So it is very important for us as a pediatrician to stress physical activity and a healthy lifestyle. And there are more important things. The psychology, again, we know that their education level is not that different compared to the general population, but we know that there's a greater risk that the retirement is earlier and that they have a lower occupational status than what you would expect when you look to education. So there are psychological factors which play a role. Fertility, it's something we already discuss when we have a diagnosis and of course when we are talking about puberty. And that's oocytonation, that's a possibility, but it's so important that the multidisciplinary team is involved to prevent at least aortic dilatation and rupture. Comorbidity, it starts already young. We talked about earlier, of course, the ear, which is important. It's the hypothyroidism. And of course, all the things what lead to a better or worse lifestyle, of a part of a lifestyle. And there are other comorbidities, other things we have to take care for. So I think it's important to improve the outcome. I think we need, of course, knowledge and evidence to give a better individualized treatment. And of course, we have to find a balance between screening and medicalization and treatment or waiting and following. We have a guideline. Please use the evidence and the recommendation what we have put in the guideline for daily practice. And I think that's we have to take care to prevent complication and premature mortality. And I think it's important that we as a pediatrician focus on healthy behavior as well in the general population, but in Turner syndrome especially. And it's important to have a registry, and we're working on a registry to have that as well. So I would like to thank you for your attention, and I give the word back to NILS.
Great, thank you very much. So yeah, there's a few questions coming in already. Oh, Erica is very quick with typing. Oh my God! So shall we? You've answered this, Erica, but shall I read it out? First, thanks, Erica, for the wonderful presentation. My daughter is asthmatic and had atopic dermatitis. She has been on intermittent steroid therapy for her condition, including topic applications. Now she has hirsutism, loses weight quickly. Any ACI dangers?
Yeah, do you would like me to answer that, Niels?
Yes, please.
Yes, it's a very good question because it is important to note that if a child is on multiple preparations, for example, combination of inhaled with topical or inhaled with intranasally, that although chances are really low, there is a chance that in a small subgroup that these children are quite sensitive to this medication and they can show side effects. So, and usually the physicians that treat them are not pediatric endocrinologists. They don't prescribe that. So these are not always very much, it's not on the top of their mind that there could be adrenal insufficiency. So yes, if there are unexplained complaints, then I would advise to ask your physician whether there is a need for testing. And they can, if they don't know that themselves, then they can ask a pediatric endocrinologist in their neighborhood.
Okay, and shall we stick with corticosteroids for the moment? Are there any cases where corticosteroid could be stopped abruptly?
Yeah, that's yes, that is possible. Corticosteroid can be stopped abruptly. If you're talking about systemic corticosteroids, in general, we say when you use them for less than 14 days, then there is no risk of adrenal suppression. And so it also depends on, again, on dose and duration. If you use, for example, inhalation steroids, they can be stopped abruptly. If you use high dose corticosteroids for really months and months, then the advice is to taper it. What about somewhere in between? That's always difficult. We know that below 1 month, if you use it for less than a month, risk is really low. So some people stop it abruptly, but some taper it. I hope that's the best answer I can give at the moment.
That's great, thanks. Theo, what is the difference between Turner syndrome and inactivation of X chromosome? Why does a single X chromosome cause infertility and other abnormalities in Turner syndrome subjects? Well, that's another talk.
Yeah, that's true. But the question is not totally clear for me. The question is it a total inactivation of one of the X chromosomes? I think it will lead to the same problem. So is the question that a part of the X chromosome? I do not understand totally the question. Niels, perhaps you can help me.
The
question is,
so I have to admit I'm also not entirely sure, because there is inactivation of the X chromosome. How I would interpret it, I mean, what would be good if the person who sent the question could send a follow-up. But how I understand it is, there's usually people have, or women have, one inactive X chromosome, but then there is, why does it cause a problem in Turner's? This is how I would understand it, but it would be really good to...
In general, yeah, okay. Again, in general, we do not exactly know. When we take the, for instance, the part which is responsible for short stature, and that's not totally the answer on the question, but we know that you need 2 SHOX genes, so that escape the inactivation. So it could be that it plays a role as well in other parts of the X chromosome. Because normally you can say, yeah, if it's a normal phenomenon that there's one X inactivated, why do you have a problem in Turner syndrome? But that's particularly because some genes, you need both of them. So I hope this is an answer for the person who asked the question, and otherwise we will hear.
And that's presumably the same with your interpretation with infertility, isn't it?
Which it is, I don't think that it's that is not so clear, but why you need both axes, and why when one is activated, that it will lead to infertility. Perhaps it will be, but in my view, it's not totally clear.
Okay, so there's another. Well, I asked myself this question: what quality of life can be expected for a DSD patient? Crikey. Don't know. I think this is a really tricky question, because it's, I wouldn't bunch them all together. So I think this is heavily dependent on the underlying condition. And I mean, in general, like with every chronic condition, there are effects, but I hope this is not too evasive. I think it's probably a whole symposium to discuss that. I'm not entirely sure if that makes any sense. So I think I wouldn't say there is a blanket statement one could make about it. Hold on, it's just at the moment. Let me have a quick look here. Would be good to have a few more questions. Like, is that something? Or Erica, can I ask you, have you got experience with salivary cortisone? Yes. and comparing that, because there's some stuff going on at the moment that salivary cortisone might be even better than salivary cortisol.
Ah, oh, that's cortisone, you mean? Well, at present, the short answer is I cannot give a good measure on cortisone, which we really can use in clinical practice. At least we are not at that moment yet. So in clinical practice, I use cortisol. We do use cortisone in hair measurement. As you know, we have the possibility now to measure cortisol and cortisone in scalp hair. And there you can look at cortisol in a timeline and look a bit like an ABH1C of glucose. This is the cortisol in hair is for the cortisol measurement of the past few weeks or months. And there we also see that cortisol sometimes correlates better with outcome variables of its, but we don't, I cannot answer it completely. Maybe you have additional information on that, Niels. Do you use it?
No, but there were papers, but there were, I think there was some stuff published, one group from Germany and colleagues of mine in Sheffield, that cortisone in saliva seems to correlate very, very well with plasma cortisol concentrations, but in clinical practice, no. And no. Can I just, what cortisol assay are you using? Because you mentioned it, that the concentration heavily depends on your on the assay you're using.
Yes, well, well, in general, the immunoassay is much used internationally also because it's cheap and it's fast and easy. So we also use an immunoassay of Roche. However, if we want really sensitive and specific information, we use mass spectrometry for all types of steroids. And we now have the possibility, for example, to also measure not only cortisol, but also profile of synthetic glucocorticoids like prednisone and dexamethasone. And that can be worthwhile in patients in which you have, for example, compliance questions, or when you want to make sure that you are not measuring the synthetic glucocorticoids. And that might be a good message also to the people listening, that it's important to understand if you have a patient that is still on a synthetic glucocorticoid, be aware that you could also measure that, especially when it's hydrocortisone. You measure it one-on-one as cortisol because it's exactly the same. For prednisone, the cross-reactivity in the immunoassay is much less, but still, when you have just had a prednisone dose, you can still have cross-reactivity in your immunoassay. And for dexamethasone, it's even more or less, but be aware of that. Realize, what are we really measuring?
Niels, may I ask a question to ERICAN?
Pardon? Yeah, sure.
ERICAN, I have a little bit a complicated question, but is there an explanation why the adrenal is so lazy the adrenal or the pituitary renal axis so lazy in coming back to normal instead of all the other axes? Because I think we don't see that with TSH or growth hormone. Do we know something about this?
Yeah, that is for my part, that's a multi-million-dollar question, a very good question. I've been asking that myself. When you look at thyroid hormone, you can abruptly stop it and your own axis will take over again. And that's much less the case in adrenal. I don't know. Although I must say it is a different axis in the sense that it has a much more regulation, because it has a much larger daily rhythm, for example. And on top of the daily rhythm, it also has little ultradian peaks. And it has sensitive regulation when you get ill. So the axis is much more sensitive to regulatory, to feedback factors. And I think that might be important.
It would be good if someone would, I'm not sure if it's only the three of us at the moment.
I hope not.
Is it okay if I ask you one or two, because there were a few things I was interested in, what you do with Turner's at the moment. What are you giving patches now in everyone, or from the age of 12 or earlier, or low dose patches? Or, I mean, estin and estradiol is not very popular anymore, isn't it?
No, for me at least, but I think more and more people, more and more pediatric endocrinologists in the Netherlands are giving transdermal. But it depends. Of course, you have to ask the patient, because some girls really don't want it. But of course, it depends on how you explain it as well. If you say, we think that this is the best, of course, we do not know for sure what I explained, but we think it's the best, you can start. And if we have the diagnosis early, yes, from the age of 11, when we see that there is no puberty, when the gonadotropins are elevated, yes, we start. And sometimes when you have a later diagnosis, you can say, okay, I waited just a little bit more. But the idea is, when you give the very low dose and you keep that low, that it is not a negative effect on growth. So that's what we give. And of course, we have sometimes the problems with availability. Then for several months, one patch is not there, and that's sometimes a problem. And sometimes we switch because they want to go back from oral to transdermal, or from transdermal to the 17-beta estradiol pill. And yeah, that's fine. With stress, particularly, that they have to use it and that the positive effects. But for me at least, I start with transdermal. Yeah.
And if you're using an oral, what are you using? Are you using ethyl estradiol valerate, some?
Yeah, we have the advantage that we have Cetura, and Cetura is 17-beta estradiol. So that's a little bit the same as Trace, I think, and that is available in the Netherlands. And you could split it up in a lower dose, 0.25 milligram. There are some pharmacists, but not that much, who can make a capsule of even a lower dose. That would be even better, because sometimes you have very short, thin Turner girls. They even need a lower dose, but that's not always possible. And ethyl estradiol, we have done that for several years, I think, in our country, but the last I think 10, 15 years, it is becoming lower and lower. This particularly 17-beta.
Okay, can I ask you one more
I
question?
also have a question for you, if
yeah, okay. Well, I'm trying to avoid that.
Well, I think the audience would like to hear it.
Okay.
I saw in your presentation you said something about Andractim, the DHT transdermal, and I'm sure a lot of people see patients that wonder whether their child has, for example, micropenis, and we sometimes get that question: when is it DSD, and when is it something to treat, and when is it just a range of physiology and do nothing? Can you say something about that?
Well, there are so that's the quirkiest centile I think that exists. There are penile length centiles, and I think this goes back to the other bit that we try to measure things, and it's in particular with kids also being a bit more overweight. It's sometimes really tricky, because you would probably see the same, that sometimes the penis is disappearing, the suprapubic fat and other things, and you really need to pull it out. Sorry, that sounds really brutal, but when Andractim gel is available, it's really powerful. In some forms of DSD, when it's not a androgen receptor mutation like vulvar reductase or so, the phallus seems to grow really well. That has a massive response to it. There are, if it's other conditions, I'm not sure if I'm answering a question, but if it's other conditions, it is hugely variable. It's a bit like with testosterone, and I'm not so sure that in other conditions it makes a huge difference in terms of outcomes. I think it's probably not too different to testosterone. I don't know if that makes sense. With micropenis, micropenis is tricky, isn't it? It's those two different things really during embryology. So if there is a problem, that's what I said also. If there's a problem before in the first trimester, then you usually have hypospadias, and that is independent of gonadotropins. And afterwards you have your phallic growth. And my impression is that in kids with with hypopit, androctem doesn't make a huge difference to giving them a boost with testosterone?
Yeah.
I don't know if that's,
Yeah,
but androctem is available because it's often not available. That's the other tricky bit with androctem.
Yeah. Thanks.
Yeah, I don't know if I answered the question. If there's, I mean, the question is, are the organizers there? Hello. The question is, if we, I mean, I have one more question around the growth hormone treatment and stuff. 60 micrograms. What are you doing that regularly, or how high are the IGF-1 levels going up? Because that's just something in terms of we've become by far more cautious with giving high doses of IGF-1, in particular with at least that's in the young adult clinic, that most Turner women, once they are 150 centimeters, are not too bothered about their height.
Yeah. So it's particularly not the standard dose. No, not the standard dose. And there are not so many girls who need a higher dose, or we give a higher dose. So, and yes, we know that we have published several years ago, I think in the GCM, the IGF-1 levels during the study which we have done in the past with the 60 microgram per kilogram and the even higher dose, and you see a higher IGF-1 level. That's true. You see an increase in the IGF-1 as well. And a colleague of mine has looked for the free IGF-1, and that's always tricky because we know not so much about free IGF-1 levels, but they were not that increased. So in general, we can say we don't start with it. We think about it, particularly when we have not so much time left and the girl is very short. Then we think about it to do the higher dose. And then you have, or you hope that your IGF-1 is not that high. And we say, okay, when it's less than +3, we will accept it for a few years. And otherwise you have to decrease the dose. That's true. Yeah.
Okay, thanks. There's one more question for Erica, and it's regarding cortisol test. Should we use either salivary or blood, only one, or even adding urinary determination?
Your arm muted. Yeah.
Sorry. Yeah,
No.
that is absolutely an interesting question. Of course, we also would like to do that because it's very patient friendly. The point is that we don't exactly know what the cutoff should be and what the timing of the sampling should be, because we are currently doing a study on that and comparing ACTH test in serum and in saliva, and to see, and what we do see, of course, we know that salivary cortisol has an extremely high correlation with serum cortisol. So we do see perfectly well a peak, but we don't know exactly whether there is some time delay. So there is a delay between the cortisol peak in serum and in saliva. So there are still two questions, I think. What should be the cutoffs and what should be the timing of sampling? And I don't have a ready, there is limited, but there is some literature on it, and people also try to do that. And but I think that the information is not general enough yet to give a general advice on that. But that will come.
Okay. Right, guys, fire off your questions. Because I'm running out, I have to say. And shall we just wait a few?
No further questions.
No further questions from the audience. Yeah, let me thank the speakers. Well, it's a bit weird, including myself. And yeah, so yeah, great. I really enjoyed